Thanks for joining me this
Of
morning.
course. Thanks for having me.
Yeah, it's great to see you. Last time
Likewise.
we were having a lovely dinner together. That was awesome. Land Ocean.
I had a great time.
Yeah, it was.
It was
Those
good.
were some good drinks
Right?
too.
Yeah.
Mhm.
That's true.
What were you drinking? Mezcal and something?
Mezcal spritz.
Yeah,
Right.
super yum.
Yeah, it was just a prosecco, mezcal, club soda, and ice.
Hmm.
Right.
Super refreshing, but a little spicy.
Right. Everyone asks me, "What? What do you drink?"
Yeah, it was
Right.
good. I had a mezcal margarita last night. It's just better than
Mhm.
tequila.
I like mezcal.
Same. So I'm with Dr. Nairizi this morning, for fuck's sake. And what's your specialty?
By training, I'm an anesthesiologist,
Mhm.
and then my specialty or fellowship is interventional pain management. So I have two certification basically in anesthesia and pain management.
Okay. And so where are you from originally? Because you don't talk like an American.
That's right. Yeah, I was born in Iran, and I grew up in Iran, and I went to school and my medical school in Tehran. And then after the medical school, I came to US, and then I got full scholarship in physiology and
Okay.
for PhD program from Penn State. So, and then through the PhD program, I wanted to take also my residency exams to start my residency as well. And then, ended up switching to master because I had to get back to the residency program. So I graduated from Penn State in cellular and molecular physiology. Then I did surgical internship first, and then I realized that my interest is not in surgery. And then I learned about anesthesia and pain management. But really, I wanted just to do interventional pain because I realized still I can use my hands, and the treatments are rewarding. But also, I don't have to take calls on weekends. As you see that the chronic pain is typically been there for years, so there's not much of true emergencies.
Mm-hmm.
So it might have a better balance in your life. But when you have family, kids, and work, I thought that might be a better choice, that I can just have a passion of what I do and also have a good balance in life.
That's a huge thing. And
Mhm.
it's so, I almost went into surgery as well, but orthopedics. And I love using my hands. I'm definitely a procedurist. But it's true that if the OR is not your passion, like if you don't have this like feeling every time you go into the OR, you probably shouldn't be there, because it does become your life. And so that's interesting that you were like, oh, surgery. Oh, this is not like filling my cups. Like my bucket isn't completely full, but you like to use your hands. So yeah, it's interesting. We both kind of made like right turns as we were entering the OR, like, ooh, maybe not. But you still get to be in the OR.
Correct. So that's right. Right now, I can do minimally invasive surgeries, and then to enjoy what I do, right? And I tell a lot of also young physicians or young medical students, it doesn't mean that if you think something, that's all you have to do it. No, you sometimes along the journey you learn that's not it. So it's
Amen.
never late. If you think that's not your passion, you can change.
Mhm.
So I have done it, and I truly enjoy every second of what I do right now.
That's so awesome. And how long have you been doing it?
So I graduated from my fellowship in 2014. So it's a bit over 11 years now
You're
practicing.
just a baby.
Right? Yeah, I am. So. But it was at the moments of being a baby when I moved to Reno, and I was like a very young physician back then. So I was like a young kid in the block back then. But now I see that those physicians, the other day, it was in the OR, I look at the anesthesiologist, I said, oh, that seems like a child labor. How old are you? And these guys are getting younger and younger.
It's amazing.
Right. It was good. And I think that reminded me of time flies. Myself was a young physician back then. Now, I become a little bit more seasoned in this field.
Yeah. I went to, one of my old partners had a party this past weekend, and it was her 40th birthday. And I was like, oh God, like My 40th birthday party was so long ago, I barely remember it. So,
I had a great 40th birthday.
I saw that on the
Right.
Instagram.
I had like a James Bond theme, so it was fun.
Yeah.
Right.
There were boats involved and bikinis.
I don't know, James Bond, whatever James Bond does, I guess.
I mean, you've got the suit for it, you've got the boat, you've got the babes. I think, yeah, it's all good.
It was a good time.
Heck yeah. So, okay, so from Iran to Penn State to Reno, and now you have how many clinics open in Reno?
So we have, so what we do have, we have the Reno Tall Pain Associates. That's the chronic pain side of what we do. And then I founded in 2021 the first pain urgent care in the United States, United Pain Urgent Care. The idea was to bridge the gap in current system. So I always felt like when patients come to me, it's like, oh God, it took me months or weeks just to someone send me here to your practice. I've been from ER couldn't do anything. And so they suffer by the time get to me. And some of them, they're already on high dose of opioids to begin with because they didn't have the right tools. It doesn't mean that sometimes they say do not prescribe opioid, but you have to give them other choices, right?
Right.
So imagine I tell them, say, you just you need to lose weight and you shouldn't have any sugary drinks or any high fat food. But guess I don't have anything to offer besides sugar drinks. So it doesn't work that way. So the alternative was not there when the injury happens in an acute setting. And that's what just made me think how can bridge this gap. And I think the United Pain Urgent Care was the right choice to address this.
Yeah, it's amazing. Like I've had dozens and dozens of needles in my back. And it did take months to get to, but a lot of that was workup and trying different things and physical therapy. And I wouldn't say there was necessarily a delay in my care, but I know how to work the system, right? Because I'm on the inside.
Correct.
I know who I need to see.
You can make a phone call to your friends who is a specialist. I need to come today.
Yeah.
But not for many people. And you have to understand as yourself as a emergency physician, you know, emergency room is it's more for life-threatening conditions, right? So typically when they come here, I have back pain, and ideally, right?
Yeah.
So that's the idea. But coming with back pain, and then you just you're not having a heart attack. It's not a stroke. You don't have diabetes that your blood sugar is significantly high, and your priorities is just to save lives there. So it becomes sort of cumbersome for some of the ER, and then you try just to treat and give the medication and put the patient on the right track. But then by the time to get to their even primary care, then primary care try just to do something. They don't have tools to give medication and try to refer to the subspecialist. And this cycle goes on and goes on.
Oh yeah,
and that's the reason is. And I think it's been pretty good with our community because a lot of the ER physicians, they love that. It just directly the patient comes here and said, there's nothing life-threatening, just go to United Pain Urgent Care because they can start a treatment right away. So I think we have been able to take some of the load off of emergency rooms in Reno so they can focus more on life-threatening conditions versus some of the things that can be done in more elective setting.
Yeah, absolutely. I actually just gave a lecture to the Ollie group from UNR, which is such a fun thing. And I was basically stratifying people's options. Like if you're having this symptom, you may not want to go straight to the emergency department because you're going to spend hours, you're going to be lower priority, you're going to be frustrated, your expectations are probably not going to be met. And it's not because you're doing something wrong or the emergency department is doing something wrong. It's just not the right matchup, right? And so I have definitely had friends and family who are like, should I go to the ER with this? And they send me a picture of whatever the hell's happening. And I'm like, no. You're not going to the right place. Like, come to my house or go to your clinic or, call your primary or go to a different urgent care or something like that. And so I think that that's really helpful because I think the knee-jerk reaction is often, this is too big. I can't get in to see anybody. I'm going to the emergency department. And it's like, now nothing correct is going to come out of that. And you've actually just kind of delayed what you're doing because they're not seeing the specialist or they're not seeing the consultant that they need. I've had people who are like, I need to see the neurosurgeon. And I'm like, well, they're not here. You're in the emergency department. You're not in the neurosurgeon's clinic. And they're like, well, can't you just call them? Like, that's not how it works. And I get, like, there's a lot of systems that we're not in. I don't know how that works, but I think it's awesome that you are circumventing and offering a viable option that's somewhere in between, where people aren't in the emergency department, which is loud and uncomfortable, and nobody wants to be there, honestly. But they can actually get an intervention done.
Correct.
Right away.
Right.
Yeah.
And because the idea is also, for example, sometimes people, they talk in the epidural, if the pain happens right away, do you need MRI? So studies been done. They did it, like, basically kind of randomize clinical trial to look at these patients that they have MRI and they don't have MRI, and let's just do lumbar epidural. Really, the outcome didn't change. So you realize that how much of this thing, just in terms of getting the pain under control, a lot is about listening to patient, a good physical exam, and a clinical presentation helps you. And then the imaging kind of will guide us throughout for further treatment plan. But in acute setting that you're trying just to minimize amount of pain, and or you think, oh, how about the physical therapy? He said, yeah, but if the pain is 10 out of 10, can't even move, how would you expect this patient to get to the point that do anything?
Right.
Why not just to subside and let the patient now have a better pain, and to start doing the building and strengthening things to do. So I'm changing a little bit of what the conventional algorithm was before to treat pain. But as reality, it seems like it's not working. You have seen the opioid crisis, the use of the medication. And you know what? One of the most common reasons for someone to become dependent on opioid is when the first prescription is being given to the
100%.
patient, right? Typically in acute injuries or post-surgery. And that's the problem starts, because then some patients, it's not their fault. It's just some people, they're susceptible to...
Yeah, it pings that part of the brain
the reward
immediately.
pathway. The medication can work so differently. Someone is, oh, I don't even like this. I don't understand why people, they get hooked to or dependent, but the brain works so differently for people.
Correct.
The reward pathway is different. So why just to expose the patient, and you expose, someone into something that they can ruin their lives if there is alternative? That's my goal.
Right. No, I love that. And what you're doing is also more effective, and you're not pinging that addiction center, which, once you start that neural pathway, people are screwed. And if it's not opioids, then it's gambling, then it's drugs, then it's sex, porn. There's all sorts of caffeine, like heroin, cigarettes, all the things are in that one little nidus. And all it takes is, I'm just going to give you 7 days of Percocet because you banged your knee and are having, dude, no. How about some Tylenol and Advil and ice and let this sit? But patients come in with expectations, and it's easier to write the prescription than to have the conversation of, hey, I don't think that you're going to need opiates for this. Why don't you try this and this and this? And then oftentimes you're butting heads with people because you're not offering them what they want. And so the easiest and smoothest pathway is just to give them what they expect. Correct. And I think that so many physicians fall into that because it's just easier to not have that conflict, especially since you don't have a lot of time.
I totally agree. I have that conversation with many patients. I said, you know what? I can walk into this room and write the prescription, what you want, and walk out and it's done.
Yep.
My day's just no conflicts, easy patient to see and walk out. But have I done the right thing?
That is absolutely correct.
So my requirement, because you feel like I may not be compassionate because I disagree with the plan that you have. But that's not the case. That's not the case. The reason is I'm compassionate, but I don't think that's the right way to address the pain. Right. There are so many other treatments that can be done. So I sit down and talk to my patient, and would try just to guide. It may just not be easy. It's like any family. You build the relationship with your patient, right? And you try just to get to the point that we'll work with the patient. At the end of the day, I said that needs to be a mutual agreement. I cannot force anything. The way that it cannot force me to a treatment, I have just to agree. But also, if I offer you treatment, you need to agree as well. So become agreement in order to continue. And I've been very lucky that most patients, when you explain, reality is majority of these patients are they're amazing people. They want relief. They don't care about anything. They don't know how to get there because they hear, oh, the pill from someone help. I want. Right. They're not there just to ask for pills. They are there just to get a relief. Somewhere that they can get back to their normal life. It can be just, playing with their kids, just going out and just, walk their dogs. So it's very simple things in life that they're missing. They're looking for a relief. But they don't know how to get there. So it's my job is to guide them, just to say, okay, show them step there and say, okay, from now on, you're on own, because you need to change your lifestyle. You change everything around it. It's not something that I said, okay, because people are familiar with diabetes, right? So there's so much awareness about diabetes that people, they know that they can't have a just bad diet and eat high sugar and use insulin. It doesn't work that way. You have to change your whole lifestyle around it.
Yeah.
I think there has been amazing work done in terms of raising awareness for diabetes, but not much for chronic pain.
That's so true. I have to tell a little story. So I played nurse at a summer camp for 5 years. Fantastic stuff. And so you hand out the medications that the kids bring based on, the timeline that the parents have given you or the guardians have given you. And so there was a young girl there who was supposed to get 2 lactose pills at breakfast, lunch, and dinner. So 6 pills a day. And I was like, what are we doing here? And so it was taco bar day. And she's like, I think I'm going to need 3. And I was like, how about if you just don't have the cheese and sour cream? Like, those are the only 2 things here that are going to make you feel bad. So if you just avoid those things, then you don't have to take the pills at all and you feel fine. And she just looked right through me like I was a complete alien. I was like, let me also say that I'm a physician and I also can't have dairy. And so I don't take pills, I just don't eat it. And then you're not exposing your body to something that it can't tolerate. And then you don't have to take the pills. Like, do you see how this works? And it was like nobody had even talked to her about this. And she was like 11 or 12. She was perfectly old enough to grasp this thing. And I think and I extrapolate that out to adults where it's like, oh, if I just take the insulin, I can have the pie. And it's like, nah. I mean, you have to address your insulin so that you can have a little piece of pie occasionally, but you don't just like garbage dump ice cream every night and pump up your insulin. Like, you're still doing damage, right? But I agree that chronic pain is not necessarily explained in that way. Where people are like, oh, if I just take a pill, then I don't have to worry about the fact that my knee hurts. And it's like, well, but maybe you need to change your shoes and get physical therapy and work on your hip strength. And maybe you need an injection, or there's a lot of different options instead of just popping horrible pills that are doing terrible things to your brain.
Oh, yeah. Always I think, there's a pill or there's a surgery that's going away. No, I think it requires a lot of lifestyle changing. And it's been also the culture, we always look for a shortcut. Oh, something that always a boom fix. Give me, I don't want to get through this. I don't want to just, for example, look at obesity, right? It's always still the magic pills, the magic injections. But the reality is, at the end, you stop, things comes back if you don't change your lifestyle. Chronic pain is the same thing. I can do the best, the minimally invasive surgery to get you there, pain goes away. But you injure yourself right away if you do not change your lifestyle, if you don't condition yourself, if you don't lose weight. So constantly it requires the patient to be reminded that we're here to help, but I can do to some extent. It's just this problem. We have each part of them we know we have just to kind of participate. It's a comprehensive treatment in a way.
Yeah.
That I can do one part, but you need to do your own part to be able to get there.
Absolutely. I would say I'm definitely guilty of not changing my lifestyle because I have chronic reflux. I have had that since I was like 18 or 19. And I'm having the mezcal and I'm having the salsa and I'm eating the marinara and like, but that being said, I have done several things where I'm like, I'm not going to do this for a couple of weeks. And okay, I feel fine. And I go off the meds and it just flares right back up. So I'm like, okay, this is something in my body. So I'm just going to live my life.
It's because it reminds me of you probably acid reflux. I was a medical student and I was trying to educate a patient. And I said, okay, for your acid reflux, you shouldn't drink alcohol, you shouldn't drink coffee, no chocolate, and no greasy food. And then I walked out. I said, God, that's going to be a very boring life.
Right.
So I'm not going to do myself. It's very difficult. You know, I have to understand.
Right.
I was like, oh my God. I mean, so you're taking the things that I may enjoy, but I think it's all about the moderation.
Yes.
Right? Life is about the moderation. What we do is not purely stay, but it's all about moderation, that we need just to minimize some of the things that, you know, you may not do well.
For sure. My physical therapist, so I had shoulder surgery a few months ago, and she gave me the bad news last week that maybe I shouldn't be playing pickleball. And I looked at her and I was like, well, you can just shove that idea up your ass. And I'm supposed to be playing pickleball this morning, Ollie, and I'm not. I was like, okay, I'm going to go do this interview. And so I did my stabilization stuff this morning, Danielle, and I didn't play pickleball. And so again, moderation, like I'm not going to quit playing pickleball. I'm going to be there Monday morning. But yeah, doing other things. Last week, instead of going to play pickleball, I did paddleboarding because I was like, oh, core stabilization and working on my lats and doing the things
even
for
with
my shoulder.
Your pickleball, if you play, maybe you don't have to you're not the athletes. It's not like I say that in a race. Maybe just let the ball go if it's too far. You don't have to reach your arm and legs to get the ball. So
I know we don't know each other very well,
but you can lose the point on that wall. Okay, get to the balls that you know you can rest.
It's not going to happen.
So some of the things you wanted to stretch, I'm going to catch a spot as if my life depends on this point. So you just, I'll tell that this is this is not the way you live off of it. So just let it go. That's okay. You lose a point. You play the game tomorrow. Enjoy the game. So I think that's a little bit of hard concept if you're a very competitive person in games. So that's the thing. So you have to let those difficult points go away. So then you have a better chance not to injure yourself.
Yeah, when I first got pregnant, I knew that I wasn't going to be able to ski that season. And so my husband and I went up to Mount Rose to basically turn in my pass, right? Hey, pregnant, can't. And I was like not showing, itty bitty baby, like 2 months or something. And they were so sweet and so kind and lovely. They always are. And they're like, oh yeah, we'll just, this will be credited for next season. No problem. I think she did that for both of us. And she's like, if you want to take a few runs now, like I'll give you a free day pass. And we had come prepared to ski. So it was like, okay, that's lovely. And so I took 3 runs, almost got taken out by a snowboarder and wrapped myself around a tree. And I was like, I can't control myself. I need to get off this mountain immediately. Like I'm such a dork. I just stop it. Yeah. So I can be a danger to myself.
I some of the things I love running, I like sprinting, but I know that if I get to those competitive situations, I injure myself. Then I don't enjoy it because I enjoy the everyday workout. But I have learned that, I used to swim competitively.
Oh, wow.
Right, for many years. But I have to accept the fact that, my body changing over years. I'm not able to get those numbers that I used to get. But I still enjoy doing it. So I have to kind of modify some of the things. If I sprinting so fast, I don't do it anymore. I try just to go as hard. I push, but I say, okay, forget about it. And then some of those coaches in the class, go ahead, it's just like, then they push. But I just shut myself off of that. And I try just to continue what I know I can do well. Because then that gives me a more sustainable way of doing workout, which I can kind of do it days and months and years versus the things that I injure myself, and then I'll be sad about not being able to do anything for like a few weeks.
Right. Yeah. No,
It's a learning curve. It's not easy.
That's so true. And some stuff I'm very good at moderating, but the athletic stuff, I'm a stubborn idiot for sure.
That's very difficult, right?
Mm-hmm, for sure. Yeah. I'm not wise in that way. So back to chronic pain. So what are some of the conditions, the top 3 or 4 conditions that you see?
So the top common, I would say, is just typically spine related, right? We do see more of back pain and the neck pain. Then the third is the joint pain. These are more common problems that we do see, but we treat all the variety of pain, from migraine headache to pelvic pain to abdominal pain, but it's not as common as even statistically. You look at people who complain from back pain, is way higher than for example, for abdominal pain or pelvic pain, and these are the common issues that we treat in practice.
So then here you're doing like epidurals and nerve blocks, and do you do Botox injections for migraines and stuff like that?
Correct. So first, we try to understand where the pain comes from.
Mm-hmm.
That makes the job much easier. As I said again, you hear the story of the patient and try to understand what the pain comes from, and you may just do some further diagnostic treatments to do. And then when you have some differential diagnosis, there's nothing that was said that you can say, oh, the pain can be very complex.
Absolutely.
So may come from this part, but also the other body part can contribute to your pain. Just give you an example. For example, last night I was giving the educational seminar for patients in the community, for people in the community, talking about a missing piece of back pain. It's a sacroiliac joint dysfunction. So it's very interesting with the SI joint or sacral joint dysfunction. This pain can present in every aspect. It can look like sciatica. It can look like a hip pain. It can look like your lumbar spine. So it can be very confusing to address. And guess, you can literally have a back fusion and not to be the reason for the back. It just may come from SI and totally miss that part.
So the SI joint, you guys, is where you're...
Right, the dimple right there. You point the
these guys.
Yeah, it says right there. That's where they...
So this triangle, these are actually joints. And so there's ligaments that hold them together. And it works very much with how you're walking, how you bend, how you move, like everything. Everything comes from here.
Right, and that pain can just go down to your, groin. Interestingly, it can go down to your leg. It can be the calf. It can be the buttocks. So it can present in different way. But guess, if you have your MRI that shows there is a nerve impingement on your lumbar spine, so many people, I think I found the reason behind your pain. And guess, let's do the treatment. Boom, man, let's do the surgery. And then you walk out, oh, my pain didn't go away. Because we simply missed a very simple, easy to rule in or rule out. And that's what makes the pain or injury complex. So you have just to do different ways to understand and rule out and just narrow down your diagnosis in order to improve the outcome and to offer the patient the right treatment.
Right. So in medical school, we're taught that MDM, as Dr. Nairizi was talking about, and it's basically like you get the history, listen to the patient, you do a physical exam, and then the next thing is you list out what are the possibilities, and kind of at the top are what's going to kill this patient. I mean, in my mind, right, as an emergency physician, what's going to kill them? Are any of these things on the list? And so when we dictate, we actually say, it doesn't look like, there's a clot, there's a stroke, there's a dead leg, there's a tumor, there's a blockage. And so we go through all of that. And then you go to what are the real possibilities? And then further physical exam or studies or whatnot, you rule out and you cross off the rest of these things. And so it's a whole process of what are the typical things that cause this problem and concern? And then you go down the list and cross those things off. And it is, you have to collaborate with the patient. When you're in the emergency department, they might not be talking to you for a variety of reasons. And so that can be really difficult because they're an adult, but it's like dealing with a 7-month-old. Like, they can't tell you anything. So at least all of your patients are walkie-talkies, as we say.
And that's what, so we're talking. So different conditions you have to understand. It can be the migraine headache. Look what the reasons behind the migraine headache, and so we treat. Can be the Botox, it's amazing results, or some of the injections can be done right now that are used for migraine headache. But also you have to understand what the triggers are. The lifestyle, just my wife, for example, she's dentist. She's get a lot of this headache and neck because constantly she's hunching over, and she does kids, so pediatrics. So leaning over the patient. So you have to change your lifestyle around some of these triggers to help. Again, we try to get the pain away, but also we need my patients' help. Just to get help from them, that you also need to change some of your lifestyle around what you do. And the treatments can be different in a way. Sometimes the occipital neuralgia, for example, they may come from their neck. So we do the radiofrequency ablations. We do a diagnostic test behind it to rule in or rule out. And then for example, for pelvic pain, a lot of the female patients that we have, we may just do like hypogastric plexus block. And while we're trying just to understand what the reason pathology is, sometimes it's become chronic pelvic pain, that they had injuries before, endometriosis, and then the pain stays there. And then we'll try just to sort of change the mindset around and change some of the with stimulation we have, for example, such as like a spinal cord stimulator. We try to change the pain signal, because that the injury's been done. So constantly the body sends this pain signal into the spine. Spine takes that up to your brain, and brain analyzes this as a pain signal. So then I said, okay, how can I change this? If I know that when you have pain, the nervous system is like electric circuit, right? You have a voltage, you have a resistance, amplitude. That's the way the wave forms and the brain analyzes. So what if you have a system that we can change these parameters around it, and I can change a different frequency around the nerve, stimulate the nerve differently, and interfere with the signal. So then you're able to treat the pain. So someone such as a spinal cord stimulator acts like that. It changes pain signal in the brain, and the body can just ignore the pain in a way and to be functional. Because we know that pelvic pain is not structurally is going to cause further damage, but the nervous system keeps firing for no reason.
Right.
And its pain has become so interesting, the technologies that we have seen, the studies, that we are able to offer different sort of treatments for the patient, and based on their needs, and kind of to tailor that to what they need.
That's so brilliant too, because it used to be like hammer, nail.
Right.
Those were the only two answers. And now it's fantastic because the research is catching up and doing more things, so that if there is just this wiring problem, you fix the wiring. You're not actually fixing either end. Like, your brain is fine, your spine is fine. We just need to snip that signal that's doing something erroneously, right?
Correct.
So, yeah.
In complex regional pain syndrome, that's all we know, that is a wind up in the nervous system, that the signals are wrong. Although you look at the fracture is healed nicely, or everything is healed, but the pain is still there. And then the patient tells, oh, I was told that is my brain. And they just get depressed. They think there's something wrong with them. Everyone says, no, that's in your brain. And it's just you think you have pain. But no, the reality is the person feels the pain.
Yep.
So the pain has come from nervous system somewhere that keeps sending the wrong signal all the time. Although there's nothing you can find in the imaging, everything has healed. But there are people who suffer from pain because the nervous system is sending. Think of a seizure. It's not a seizure in the brain. It's a seizure in your peripheral nervous system. It's just those signals going back feels like a painful signal. And that's where we come to play to how I can change it, how can I dampen that. And that's as a way of treating those sort of pain.
And actually, that's why people sometimes will end up on antidepressants, because they have chronic pain. And what you're doing is trying to regulate the neurotransmitters that are receiving that pain. So it just kind of dumbs it down and dulls it down a little bit. But it's true that chronic pain is very closely related to depression, because if you have to deal with something that hurts all the freaking time, that's really going to bring your mood down and mess with your neurotransmitters. And so at some point, you're not sure if it's like the pain causing the depression or the depression causing the pain, right? And so sometimes you have to come at it with a two-pronged approach.
Yep, the pain, you brought the great concept of depression and pain. And in some situations, when we see the patient, we don't know if the depression is the reason behind the pain right now, or the pain is the reason behind the depression. So it can be very confusing. But I can tell you that these are some statistics. We always use the statistics in order to understand the pathology better and see how many people they do suffer, and what is this something that we have to look into strongly. And chronic pain, so think of in US, according to CDC, we expect to have 60 million people in US to suffer from chronic pain. That's a huge number, right? Huge number. And then when you look at the National Institute of Mental Health, number that they put out for depression, there are around like a 21% of adult population, they have experienced severe depression episode at some point in their lives.
One in 5 people. 1 in 5.
Yep.
Think about your friend group. That's a lot of freaking people.
And when you put them together, then the pain and the chronic, so we always look into, okay, how would address them? But I know statistically, again, if someone suffered from chronic pain, I would expect the 40% of this patient also they suffer from depression.
Mm-hmm.
That's a huge number. Again, in our practice, imagine that 40% of my chronic pain patients, they can have some sort of depression.
It's almost half.
Correct.
Pretty much half.
Right. And then from them, they can be basically up to that 40% to 10% to a little bit higher can have severe depression. Those are ones that definitely need just to catch.
Mm-hmm.
And then my job is also what else I can do to help them. Because when I was talking to a friend who's a psychologist, helps us with pain psychology, said something great about it. Said, think of you have a layer of just ice. That's a mental part of the pain, because pain itself has emotional component,
absolutely,
and it has a physical component, right? So if you have sometimes you have the people that said, "What's your pain?" "Oh, I'm 10 out of 10." You okay? "Yeah, I feel good. I'm good," because they haven't been hit emotionally so hard. Versus someone have that it's a pain, yeah, it's just 5, but they cry because the emotional component of the pain is significant.
Mm-hmm.
And when it gets to the point that the emotional part or the strict anxiety, it becomes a sort of a layer of it's sort of like a layer that they cannot penetrate into. So you have to find a way to take that layer off in order to be able to get into the pain, the physical, to treat.
So deal with the sadness and fear and anxiety level so that you can actually get to the physical part of it.
Correct, because if I don't address that, I never get a chance to treat the patient. I never get that to physical, because everything is just covered with that layer of emotional, the anxiety, depression. So I have to address that at the same time that I'm addressing the physical, in order just to melt that layer and let the patient just to get to the physical part of the pain to treat the patient. So it makes it challenging, but also, again, it's at the time that I get help from colleagues like pain psychologists to try just to learn some of the points to the patient, that how they can cope with some of the issues that we deal with. And nothing is perfect. Expectation from the treatment is the key.
Sure.
As well, that if don't think this is like you fracture your toe and it's painful. Your fracture is painful, but it heals, pain completely is gone, right?
Right.
Chronic pain is not the way it is.
Yeah.
This is not many a time you see that the body has healed, the pain exists. So it becomes very, very more difficult to get to the point of like treating acute pain.
Yeah, because now you've got a dysfunctional pathway where
correct.
The accuracy of the injury is not what the brain is perceiving. And yeah, I can see how the psychology of that is like, well, now specifically, I don't understand. My toe should be fine, but I'm still feeling it. that can be very anxiety
And that makes you anxious, makes you depressed, because your life revolves around it. And sadly, what we have seen that the family falls apart over chronic pain as well.
Oh yeah.
So I can see that because I can foresee the situation for a young gentleman who's got pain maybe a year or two, comes in with the family, and like the wife presents their kids. But if this is not being managed correctly, it becomes difficult for your partner, for everyone around you. You start seeing that the anxiety among the family, things just gets more and more and more, and then it results in even separation, divorce, falling apart. The support system goes away.
Yep.
And so we take that very seriously in terms of we try to say, you have to do and help yourself.
Yeah, we see that in the emergency department a lot, where it's the whole family is feeling the pain, right?
Mm-hmm.
Because the anxiety and depression has gotten so bad that people have lost their jobs, or they can't function anymore. They're in bed all the time. And literally it's like this team effort. Everybody's glued together by this dysfunction. And oh my gosh, getting into that and digging through it, like it's impossible to do in the emergency department. We don't have time for that. But you see it so frequently where you walk out of the room and you're like, I can't fix this today. This is years in the making. And so thank you for taking that on. Because it's so real and it's true that it just is so far reaching.
And the reason you and I were talking about it means that can be resolved. So, but you have to raise that awareness, that you have to take this very seriously. You don't let it go on and on and on. As soon as I talk about the emotional and anxiety and depression, a lot of these patients said, you know what, you call me, no, I'm not going to see a psychologist. I'm not crazy. I said, it has nothing to do where that conception comes from, that this is just to understand this is going to happen and it's going to make you anxious. You try just to go to work, you try just to get through your work, the pain is there, and I said, God, I can't do. And then you try just to think that medication is going to resolve it. You take more and more and more, but the outcome is not going to be there. And so we work with them and say, but you have to help yourself as well. So the treatment is there. And the good news is there are so many alternative ways of addressing, but it has to come from yourself and having the sort of insight of what you're going through, and try just to be open to get the help from people who have done this, from the experts coming in and help you. And you have to understand, again, this is not acute pain. So it's not like, got fractures, you give it some time, heals, goes away. No, it requires multiple disciplinary treatments from psychologists, from interventional pain to other departments of rehabilitation to get you back on track.
I love that. So let's talk about the weird machine that you work with that I'm fascinated about.
Right. So you're talking about the TMS. So that's transcranial magnetic stimulation. That's a machine we have for depression. And the reason is, in my practice, we have lost patients in depressions that sadly they took their lives. And I had the veteran patients that just sadly, and I thought, I worked and I thought I can capture these, but there's situations that I couldn't believe why. I mean, I didn't see any signal, and maybe I need to do more, because the patients these are the patients that become your part of your family. You do see them every month or so. They just lives. How many of these presents gifts that they have there? He made me a beautiful knife, handcrafted knife for me as a gift, things of God.
Goodness.
So it's good friends, but I didn't get that sort of a signal that it just something back there. So we decided just to do more and see what I can do beside pain. And I look at the statistics that said there can be 40% of these patients suffer from depression. What can I do to help them for myself to be a better physician? And so then we thought, okay, the treatments that I can offer and help these patients in it should be easy, non-invasive, and there's no medication involved. So make it easy, then also supported by evidence. And then I saw that the TMS was an amazing treatment, that that level of evidence behind it was strong, and FDA approved that for severe depression. So it's not a shock wave, it's not an injection, it is not a medication to have side effect. It's like going through MRI machine. It stands out as magnetic stimulation, nothing different from MRI machine. Then it sits right up part of the prefrontal part of the brain on the left side, and then it activates the part of the brain that typically it's hypoactive or silent in people who do have depression. So when you have depression, those neurochemicals in the brain to activate the neurotransmitters like serotonin levels, they drop. Right. Well, you're trying to take the oral medication because you try just to balance that by sending, but sadly they have a lot of side effects associated, right, with oral medications. But this part is just trying to activate your part of the brain to start releasing those neurochemicals in more organic fashion of your body to raise that level up, to make it like more people who do not have depression. And that's the beauty of it. And when you look at again, for me, it's always studies, there's clinical trials to see. And the treatment is, when you see that they have up to 83% of these patients who have completed TMS, they have significant improvement in their clinical depression.
And how many treatments do people usually have?
Typically, it's 35 sessions. And you need to do it every day. You get the weekends off, but then you come back like 5 days a week, between like a 10, 15 to 20 minutes of sitting around on the machine, that signal that like going through MRI machine, magnetic stimulation. And then from them, as I said, 83% of them, based on the studies, have had significant improvement in their clinical depression. And also 62% of those patients who have had treatments had that full remission of their symptoms.
So it doesn't come back?
At least for the studies of 12 months.
Okay.
You can repeat that, but that's been studied like a long term for 12 months. So they have 6 to 12 months of full remission, correct, 62% of people who had the treatment. And then the outcome is, when you look at that, it's just amazing, because not a shockwave, it's not a medication, it's not an injection, it's a simple, like going through the MRI machine.
Right. So patients don't feel anything, they just sit there.
Yeah, they don't feel anything. And that's not only for the patients who have chronic depression. Whoever has got severe depression, it's a candidate. Basically, it's very simple. We call it PHQ-9 questionnaire. You're familiar with that? That's a questionnaire. It's a question that you screen this patient for depression. And if you look at the score on the side, that we have a cutoff point for the scoring system that puts them on a higher situation, means that this patient can suffer from severe depression. And if they have failed 1 to 2, because that's a requirement for insurance, and also this is majority of all insurances in the country, they approve this treatment, so they cover it. There's a great coverage for this treatment, and so the score is high. And if that failed 1 or 2 antidepressant, this is a requirement for insurance, then they become a good candidate to undergo treatment.
So what if they're already on an antidepressant? Can they still do the treatment?
They can. So the question is are they under control?
Right.
If they are under control, so may not need, but if this is not, if they're not under control, depression, yes, they can. So that's what they make them qualify, because it means that the current medications are not working for them.
Right.
So it means that they have failed, or they're not at optimal level of treatment.
Right.
Or they're experiencing side effects from it. It's that, you know what, I'm taking it, but the side effects I can't do. I have night terrors because the serotonin level is gonna up high, or I can't, it make me dry mouth. There's a lot of, but they have to take it because it addresses their depression.
Right.
So they can become a great treatment for them, TMS, because there's no side effects such as those that you do see with medication.
So there's a lot of people who can't take antidepressants, either because of side effects or other things. But I think it's important to note that, as what we're trying to do is stimulate the brain with serotonin to help with depression and oftentimes anxiety, chronic pain, things like that. but the number one organ that's affected by serotonin is your guts. And so a lot of people will have like horrible bloating and gas and diarrhea and constipation, and it can make you anorgasmic, where you get to the point where you want to have an orgasm and you can't. If you are not already depressed, that can be enough to tip you over the edge. And so they're what are considered dirty drugs, because we don't yet have the science to just do serotonin in the brain. And so if you're trying to raise the level of serotonin for the brain, you're going to raise it for everything. And a lot of your organs don't like that. And so those are the side effects that we're talking about. And so, yeah, your brain might be feeling better, but if it's tearing apart your body and making the rest of you feel like garbage, probably your depression is not going to be a whole lot better. So,
yeah, that's right.
Okay, so they sit there for several weeks, 5 days a week, for 10 or 15 minutes. Does it help with pain?
It's not been studied for pain.
As like anecdotally.
Right. And but you have to understand again, when you have depression and pain, it makes it very difficult for us to address the physical component of pain if I've not addressed the emotional.
Mm-hmm.
So I do expect that if the depression gets under control, my patients can do so well under the physical treatments that I do, or interventional treatments that I do for them, because now I'm addressing both issues.
Mm-hmm.
I'm addressing the emotional component of the pain, and I'm addressing the physical component of pain. So I would expect to get better results.
Right. And are there side effects from the machine itself?
Side effects from the machine, it's some people, they may experience because the magnetic stimulation, they may just experience sometimes a headache associated, but these headaches can kind of subside as the treatment goes by, or we need to change the angle of the stimulation. Those ones. So those are one that we have seen mostly is may just feel that sort of it like feels like in some situation like a trigeminal neuralgia type, because stimulating.
Okay.
And what we do is we change the angle. So if the patient complains that, it means that the angle of the stimulation needs to be changed. Not very few patients they experience that, but we have a way to troubleshoot.
Gotcha.
Because we expect that some people, they may experience that. So that's what we have seen the most common. But also, if there is indication that you cannot get MRI from the magnetic field, have a metal that is not MRI approved, those patients may not be candidate, because this is like, it was like going through the MRI machine. Right. So you have like a brain clip aneurysms, right? That is just metal that can't go under MRI. You cannot have the TMS.
Okay. Are those the only contraindications to getting the treatment?
These are the only, they're just, or some of them, right? Like if you have a tattoo and it's got this metal component, color-wise, dye, that's somewhere around from the neck head up. So that might be also, right? Anything that's like an MRI machine, basically.
Okay. Awesome. And how long have you been doing these treatments in your clinic?
It's been past 2 years. We have started to incorporate that into our practice, to be part of our treatments. We start looking at these patients with the PQH9 questionnaire, so we identify who are depressed. So we work more on that one, just to capture, and then we educate the patient if they are interested. It's very difficult also sometimes, because if you have depression, you don't want to participate.
Mm-hmm.
So getting you there, but you have to understand, you need to help yourself. We can show you the best option, but I need you to participate. It might be just, I'm not going to come. It's hard for me to come every day. But you have to understand what you lose, because this depression is not going to help. And that's because you feel depressed. If you're depressed, you try to stay away from activities.
Mm-hmm.
You don't want to get engaged in any physical activities, things to enjoy with family. And that's because of depression.
Right.
So you need just to understand, and then we'll help you to get there. I think these are what we've done, and try to educate the patient and give them that sort of insight in what they go through every day.
Yeah, I mean, one of the huge things with depression is just having no energy to do anything that's going to break that apart anyways. And so you just sit mired in the fact that you don't have energy, that you don't feel good. And this is not a voluntary thing, people. You know, your brain literally is not giving you what you need to break out of this. And so I can see how, you know, if you tell someone who's depressed, who has the anhedonia where they just can't even get out of bed and can't feed themselves and like have no appetite to do anything, and you're like, okay, we'll see you 5 days a week for the night. You know, they're going to be like, I don't do anything 5 days a week. I couldn't possibly. But yeah, it's definitely the driving motivation to, hey, on the other side of this, your life may look completely different.
Correct.
Right. But when you're depressed, all you can see is this, like it's just that dark wall of heaviness. And so it's going to be really hard for people to get motivated. But yeah, like you said, you just have to buy into the program and realize, okay, you know, in maybe 4 to 6 weeks, I can get off this medication that's also making my guts feel like shit and I can't come. And like, I might have more energy to engage with my kids or get outside and walk in the sunshine and things like that, which are going to then help your depression anyways, right? So like, you have to break that cycle.
And in the lifespan of, you know, what you've gone through in depression, that 4 weeks or 5 weeks is just nothing. Really, just imagine how many years of depression issues that you've been through. And I think it's that 4 or 5 weeks, if it's resolved the issue, it's worth trying.
Yes. Yeah. I do, you know, but people are looking through this veil of no hope, no help, especially if they've gotten to that point. It's been like this for years, right? And they have had so many disappointments and life is so bleak. But yeah, like your smile, your support, your willingness to sit there and listen and hear what they have to say, I think that makes such a huge difference, because we're only human in the healthcare system as well. And like, you don't want to hear that necessarily, and you don't have time to address that. And I think a lot of people don't understand that pain and depression and anxiety are all snarled up together, right?
Correct.
And so you sometimes have to hit all 3 points to make a difference. And you're making a difference.
I hope so. This is my passion. I'm in I had a lady today. She's, I think she's in her 70s, late 70s. Very nice patient. She gave me a thank you card, but said just open and read that part. And there was a very beautiful letter, and said, this is one my dad gave me she was telling me when I was 5 years old. My dad was a physician.
Oh.
So gave me this one. Has had it all the times. And it said that, you know, I have 2 daughters, and they're 4 and 7 years old. It said that when I was 5 years old, my dad gave me, it said, you know, Dad, it says that my dad is a doctor. He always puts MD at the end of his name, just to make sure that only belongs to me. MD stands for my daughter.
Oh gosh.
And it was just the sweetest thing. And I said, I'm gonna take it to my daughter. So every time I say Ali Nairizi MD, it means like my daughter, just to say that, right, I'm there for you girls.
Oh, that's so cute. What a lovely
It's a lovely, it made my day.
Yeah.
Today.
Right? So that's why you stick it out.
Ali Nairizi MD, my daughter.
My daughter. Very cute. All right, you guys. Dr. Nairizi.